where he went to medical school at the University of Washington. His career after residency has been at the Wadsworth VA and UCLA, where he undertook gastroenterology fellowship. He is the director of CURE, the Digestive Diseases Research Center Human Studies, and works as a professor of medicine in UCLA. He has been a highly prolific investigator in GI disease. His studies have defined the management of gastrointestinal hemorrhage. He has published over 100 peer-reviewed studies, publications, multiple chapters, and many editorials. He has received funding from the NIH and VA throughout his career. He has been a mentor and an inspiration to multiple trainees, many of whom went on to academic careers. Please join me in welcoming Dr. Jensen from the West Coast to Miami.
Well, thank you for the nice introduction. As this is a general medicine grand rounds, I'm going to broaden the topic, but the first part of it is on the diagnosis and somewhat medical management of severe upper GI bleeding from ulcers and non-variceal lesions. And the last half of this is going to be on what some of the newer innovations are that come from our research. And I'll leave some time for questions. So what are the causes of upper GI bleeding? In nearly 1,000 patients, which we recently assessed at 2 hospitals, UCLA and the VA, where I do attending and work, this shows a pie diagram. Still, about 35% of patients who have final diagnosis have ulcers. There's about 27% who have portal hypertension and some disorder related to that, including esophageal or gastric varices, and then other portal hypertensive lesions such as post-banding ulcers, Mallory-Weiss tears. That's because we have a very large liver transplant program at UCLA, and at the VA, a lot of patients with liver disease. The focus of this is on how to treat lesions such as peptic ulcer, doulophobes, which I will describe in a bit, and Mallory-Weiss tears that are not related to portal hypertension. You see, though, there's a fairly high prevalence of esophagitis in spite of the widespread use of PPIs. We have some cancers and polyps, and then these angioma syndromes, which are these vascular lesions that bleed in patients. But those are not amenable to drug therapy and are usually treated endoscopically. So in terms of general management, what I would ask our house staff and medical students and non-GI folks to be aware of in this management before calling gastroenterology for a consult in your patients, you should go through in your own mind and administer resuscitation, make sure that the airway is protected, because some of these patients have altered mental status or respiratory issues. You should take a general history in addition to taking a GI history and ask about and inquire about chronic liver disease, chronic renal failure, heart disease, prior GI bleeds, prior GI disorders, drugs, alcohol, substance abuse, and then also GI surgery. Not commonly done, but you should also include in that vascular surgery such as AAA repairs. We recommend that you do a general physical exam before focusing on what your area of interest is, and in the case of bleeding, if the patient is obviously not hypotensive, do orthostatics to get an idea of what the blood loss is. Do abdominal and rectal exams. You should not rely on the history, but healthcare documented melena is an important issue and directs the gastroenterologist. In selective patients who have melena, you might consider an NG or an oral gastric tube to see if they have fresh blood. We also recommend that in patients who have hematochezia, which is bright red blood per rectum with or without clots, to see if they might have an upper source. And then hematemesis in patients who have altered mental status. You're familiar with the labs, including routine chemistry panel and hemogram coagulation tests, if appropriate, typing and crossing the patient. And we feel in elderly patients, cardiac enzymes, if they have cardiac disease, are important. You should consider toxic and ethanol screens, although you don't probably have as many people who drink here as they do in Los Angeles. Selective x-rays and EKGs are important, and sometimes scans, including those with a possibility of a fistula related to a previous aortic graft, are important. That would be an MRI that you might consider. The management tips that the gastroenterologists need to look at are somewhat similar before they do endoscopy, and as they're thinking about this, the resuscitation and monitoring, protection of the airway. I'll get back to this issue of transfusion. If the hemoglobin is less than 8, not 7, 8, a goal of trying to start correcting the coagulopathies, the selective NG, if you need it, either in a patient who has melena or you're worried they might have red blood, or those with hematochezia are important. Medications to reduce GI bleeding in this day and age in patients with liver disease, they usually give octreotide in the emergency department. In suspected peptic disorders, it can be giving them a PPI starting in the emergency department, particularly if there's going to be a delay in the endoscopy. And then there are other drugs that might be appropriate for people on anticoagulants and or who have chronic renal failure. Maneuvers to improve visualization we discussed earlier, and then whether they're the urgency for an endoscopy versus some other tests and what the setting should be are the decisions that the gastroenterology consult service should make with you. Okay, I want to now focus on a series of studies that we've done that poke at the sacred cows, if you will. So the issue of red cell transfusion in upper GI bleeding and mortality, what is new? As you probably are aware of a famous paper by a Spanish group in the New England Journal in 2013, they performed a randomized study which concluded in that study that limiting RBC transfusions in people with upper GI bleeding to those with hemoglobins less than 7 saves lives. The problem with this is looking at the details. The devil is always in the details. This study has resulted in our institution of very restrictive guidelines for transfusions, especially in the ICU and out of the operating room, which are not appropriate. This is in spite of multiple exclusion criteria and other limitations of the Spanish study, which limit its generalizability, including that the death rate was significantly higher only in the subgroup of cirrhotics with child class A or B, but not other subgroups with upper GI bleeding, including cirrhosis and child class C. In addition, they eliminated anybody with severe cardiovascular disease, CNS disease, instability from this study because they needed to follow them through the hospitalization. So it's our impression that a larger study in unselected patients with upper GI bleeding was needed. And so we did such a database study to evaluate the effects of RBC, fresh frozen plasma, platelet transfusion on 30-day mortality in such patients with severe upper GI bleeding. And what we found is opposite their conclusion. If you look at a multivariable analysis, which is controlling for all other possible factors that you can attribute deaths to, we compared the highest to the lowest quartile of patients with units of blood transfused at baseline for resuscitation. And if you look at this, the red group here in non-variceal, which is almost 1,200 patients as compared with theirs, much smaller study, the odds ratio of favoring reducing mortality in this group was 48%. In other words, the highest group had a 48% lower mortality than the lowest group of transfusion. It's borderline significant. Why is that? Well, these are the patients particularly that have cardiovascular disease, they're older, they have other comorbidities. If you don't transfuse them, you get mortality. And it's often related to undertransfusion and underperfusion. With the variceal group, which they reported as significant, it's not significant. And all patients, some 2,200, it's not significant either. You can look at the odds ratio. In other words, the odds ratio in all of these is lower than 1. So it's 12% reduced if you transfuse more with varices and almost 21% in all patients. So this wasn't borne out in unselected patients. What does that mean, unselected patients? These are all the patients that my group has seen at the VA and UCLA over a period of about 10 years. So they're all of them. We reviewed them prospectively and looked at these data retrospectively with the statisticians on this multivariable analysis. What did we find the risk factors for death for all diagnosis were? So all of the different subtypes, varices, non-varices, et cetera. Greater disease severity. So non-variceal, you can see this, variceal, highly significant. Partial thromboplastin time greater than 35 seconds, depends on what your normal is. Prothrombin time, or if you want to look at an INR, elevated. Low platelets, or what's called inpatient bleed. So if a patient is admitted to a surgical service, OB, something else, and they develop bleeding in the hospital, that's considered an inpatient bleed. That's bad. What was not significant in this multivariable analysis predicting death was age, gender, specific diagnosis that I've mentioned, stigmata of recent hemorrhage, which we'll discuss, large lesion, hemostasis at baseline, or any other of 30 potential risk factors. So the message here in our institutions are that if you don't transfuse patients, and we used a baseline of 8, if you wait until it's 7 or lower, you're going to have a higher mortality, especially in the non-variceal group. You might not know whether it's variceal, but if you just think cirrhosis, not cirrhosis, you have a better idea. I want to now talk about what's been used for, I don't know if you can turn the light down on the screen, maybe you can see it. These guys in the back are probably having food coma by this time, they don't need to see. But at any rate, what gastroenterologists have used for the last 40 years have been classifications of what they see endoscopically. And the original English guy that did this in 1974 was Forrest. And what they described as the various stigmata, which I'll refer to, and they paired these to what they thought the clinical outcomes were, in other words, risk stratification. Now, this has been modified somewhat in the United States as opposed to the United Kingdom countries. We don't use this. We use descriptive terms, which I think are more helpful. Oh, that's great. So Forest 1A is arterial bleeding. These are all ulcers, by the way. This is a visible vessel, and their arterial bleeding come from it. That Forest 1B is oozing bleeding. This is an ulcer base. You see a trickle of blood, but you don't see any other, like a clot or vessel. Forest 2B is non-bleeding visible vessel. This is a large ulcer. Clot's been removed, and this pearly structure is a visible vessel. 2C is a flat spot. This one has 2 flat spots. That's the ulcer, duodenal ulcer. Forest 2B is an adherent clot, means you can't wash it off, and this is a clean ulcer base. So that, for the last 40 years, is what gastroenterologists have used as a guide to treatment. And originally, they were treating arterial bleeding, oozing, visible vessel, but not clot, not flat spot. But in the United States, based on trials we've done randomized trials, and we find if you treat this medically, about 1/3 to 35% of the patients bleed, And so these should be treated. I talked with the gastroenterologist on how to remove these this morning. You inject them and then use cold guillotine these off and see what's underneath. So what does a non-bleeding visible vessel represent? And this is one of the main messages that I have for you, is that it, for the last 40 years, it's represented a visible vessel. But what we really want to know is what's underneath it. There's an artery under that, which is what makes non-variceal lesions bleed, whether it's be ulcers, Dulafoy's, Mallory-Weiss. This is the model, though. So for the gastroenterologist, they would wash this off. But the real question is, how do they know if there's an artery under it, or that matter, a vein, and which direction it goes? And by looking at this from visual cues, you don't know. Now, you could take a GI fellow and they could take a needle and start sticking it next to this, and if they got arterial bleeding, then their attending would be very angry with them. You would know that's where the artery is, but we would recommend not doing that. If you look at the histopathology from many years ago, another Englishman, Paul Swain, published this with his colleagues in the New England Journal, looking at the histopathology of gastric ulcers that on medical management bled, and so they resected them. And what they found is that what I showed you in the ulcer before, the visible vessel represents a side hole in an underlying artery. So this, as you'll recognize from your medical student days, is an artery with thick walls, and it's been disrupted here. So what the gastroenterologist's chore is has been misrepresented. It's not to treat this side hole, which you can disrupt, but it's rather to seal the underlying artery. But you have to know where the underlying artery is to do that. So it's been a blinded situation for many years. We published many years ago, this is one of my first fellows, Jim Johnston, or Jimmy as he's known in the South. We published this concept of coaptive coagulation. This is what the endoscopists now do routinely with thermal probes. In the past, it was heater probe. More recently, it was bipolar technology. In the laboratory, by pushing down on the mucosal side of an underlying artery, you can first interrupt blood flow, which is a heat sink effect, and then you can seal arteries, as shown here by this cartoon, that are up to about 2 millimeters in size. But this is under perfect laboratory conditions. The notion was that we could do this endoscopically. And the notion also was that most of the arteries, as shown here in the Swain diagram, were under 2 millimeters in size. I might tell you, and I don't have a picture of this, Swain also published in a review paper that they had looked at fatal duodenal ulcer bleeds. You know, even in the past, when you had duodenal ulcers that bled, you do not resect the duodenum. So he looked at these from autopsy studies, about 20 patients with fatal duodenal bleeds in London, and he found that in a third of those, the arteries were bigger than 2 millimeters. So you have this threshold effect. We were never sure whether we were able to be successful. Most of the arteries that we see in gastric ulcers are secondary or tertiary branches of the main artery. In the duodenum, there may be some larger ones that are off the gastroduodenal artery, which, as you may remember, is a very large artery with high flow. The notion also with a more recent treatment, which is hemoclipping. Now, the surgeons have always used hemoclips for arteries laparoscopically or at general surgery, but in the last 10 years, these have been adapted and used in the United States and worldwide to supposedly clip underlying arteries. And this shows a cartoon of that in which the ulcer base is here, a visible vessel is there, and so rather than clipping on top of the visible vessel, what the gastroenterologist should do is clip on either side of it and thereby occlude the underlying artery. Because you cannot deal with the disrupted part of the visible vessel. This allows that to heal and scar down. Whether you can do that just based on visual cues is anybody's guess. How prevalent are stigmata of hemorrhage in the patients we see with PUBs, which is peptic ulcer bleeding, more than 400? Well, about 40+% are clean ulcer bases. Only about 6% are active bleeding, visible vessels 18%, clot 15%, oozing 9%, and the spot about 10%. So I've shown you those. In general, the guidelines that gastroenterologists have on the American Board of Internal Medicine is that clean ulcer-based patients and spot patients would be treated medically, which is usually just oral PPIs, and if they have H. pylori, to treat that. If they're on NSAIDs or aspirin or fish oil or that sort of thing, you try to keep them from taking those while they're on the PPI until the ulcer heals. On the other hand, oozing, clot, visible vessel, and arterial bleeding, which represent about 50% of the patients we see in a referral center, we treat those endoscopically. Well, what's new? How can we assess the artery under a lesion? Well, this shows a device, a Doppler endoscopic probe, a control unit, and a catheter that's disposable, which allows us to do this. This is based on a Doppler principle, which I'm not going to go into, but if you're on a tangential approach, this gives you an auditory signal that's gated by depth. So under 1.5 millimeter to 4 millimeters, and then the deep setting is more than 4 millimeters, more than 7 millimeters, excuse me. This does not give you a visual image. This gives you an auditory image. So for an artery, it's like a swish, 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 often at the lowest setting with ulcers, because they're shallow. We don't use the deeper setting except for varices or other lesions, which I'm not going to discuss. So the question is, again, if the gastroenterologist sees an ulcer like this with a visible vessel, how do they know that there's blood flow under this? Is there blood flow under it? And which direction is the artery? So what this probe allows you to do, Doppler probe, is in the base of the ulcer, starting where the visible vessel or the stigmata is, go out from that in a straight direction, and you can trace where the artery is. Also, you can tell, is there blood flow in it? I mean, it wouldn't be positive unless blood flow, and about when it gets extinguished. So usually the blood vessel on either side of this can be seen for several millimeters, about 5 millimeters. And after that, I'll go back very briefly. After that, as shown in the Swain diagram, it dives deeply and it can go right into the muscle layer. So after you're away from the visible vessel, less than 5 millimeters, the artery disappears and the signal is, and that's because it's deeper. So it can give you the location, it can give you about the depth, and it can tell you what direction it goes in. The implications for using this Doppler probe for risk stratification of ulcer patients is twofold. At baseline, you can, before any treatment, based on the stigmata of hemorrhage, you can interrogate ulcers. That's what this is. This was published in GIE gastrointestinal endoscopy, January last year. Of course, spurting 100% of the time, we detected arterial blood flow, visible vessel, 91% clot, 68%. So overall in those, which the percentage that had underlying blood flow detected is 87%. Oozing, on the other hand, 47%, and something that we haven't been treating before, flat spot alone, 41%. We considered these high-risk stigmata, spurting visible vessel clot. Intermediate was oozing and flat spot. So you keep that in mind. Another important concept is that after you do your routine endoscopic treatment, which in this day and age is at least monotherapy with a thermal technique, bipolar technology, multipolar probe, versus clipping. And you do that with or without epinephrine injection. So the question we asked in this is, in the patients who had baseline positive blood flow, when you did endoscopic treatment, visually guided, how often was there still residual blood flow? Well, in the high-risk group, it was 27%. So that is a marker of rebleeding. In the flat spot, which we only used epinephrine on and is only transient, it was 20%. And oozing is easy to treat. We didn't find that at all. So it can be used as a guide to therapy, and I'll get back to that. The next thing I would like to show the gastroenterologists, or some of you who are interested in bleeding, is whether there's a difference in the Forrest classification A and B. The notion that Forrest had is that if you're in Roman numeral 1, that's A and B, you had a higher risk than Roman numeral 2, which was visible vessel or clot. And I'd like to show you that based on current data, you shouldn't think that way. This is, again, an ulcer with oozing bleeding, no other stigmata. This is a spurting group with a visible vessel. So what we did in this study that I just mentioned to you is that the methodology was that after endoscopic visually guided treatment, the active arterial group got what the standard of care is, which is high-dose infusion of PPI for 72 hours. The oozing group, based on very low detection or no detection of residual blood flow, just after endoscopic treatment, just got oral PPI. And then we followed these two subgroups of patients for 30 days and looked at the difference in rebleeding. Again, these were patients, although blood flow was detected as a residual in the spurting group of 36%. We did not do further treatment. We left them alone. And in fact, 29% of those patients rebled. In the oozing group, where at baseline less than 50% had detectable blood flow, after coagulation or clipping, nothing was seen and none of them rebled. So these are highly significant differences, indicating in this that residual blood flow is a marker for rebleeding. Now, it isn't 100% of those with residual blood flow that rebled, but it was more than 80%. As a second look at this, there's another paper that's going to be published in the Red Journal, and it looked at a large international study that was previously published. The large international study, very briefly, was looking at patients after successful endoscopic coagulation and randomizing them at that time to IV placebo for 72 hours versus esomeprazole. And that study reported out to 30 days that there was a significant difference in rebleeding, higher, about twice as high in the placebo group than the esomeprazole. This gave us an opportunity to look at a unique group, which was the first 72 hours in patients in the placebo group, to look at what the natural history of bleeding is based on stigmata of hemorrhage. So these show those data. So in other words, in this international study, in order to get on this, they had to have spurting, oozing, clot, or visible vessel, and they were treated endoscopically, visually guided. And this group for 72 hours then was put on IV placebo in a blinded fashion. And lo and behold, the rebleeding rate in the spurting group was 23%, in the clot group 18%, visible vessel 11%, but the oozing group very low, less than 5%. If you looked at a multivariable analysis with oozing as the reference point and comparing visible vessel clot and other features, what is shown is that the odds ratio of more bleeding is higher in the spurting group, nearly 7 times, with shock 4 times, with clot 4 times, with visible vessel 2.6 times. So oozing is distinct from the other groups. Furthermore, not published in the article, even though I asked them to put this in, were these data, which are important. The blue bar here is the rebleeding rate in the esomeprazole group, and then the magenta is in the placebo group. So in every group except for oozing, the rebleeding rate was higher, significantly higher in the placebo group than the PPI group. Looking at it specifically, I mentioned in the placebo group, that is during this first 72 hours, 4.9%, and in the esomeprazole group, 5.6%. So the message here, which would ultimately help the bottom line of people that treat bleeding ulcer, is that, of course, for the high-risk group of patients, after endoscopic coagulation or appropriate treatment by the gastroenterologist, visible vessel clot spurting, those patients should be treated for 72 hours with IV infusion of PPI. However, the oozing group, it does them no good. If you stop the bleeding, oral PPIs work just fine, and the patients can be discharged if they have the support services and family backup that they need. Okay. The question often comes up now that we have these clips, and they don't cause any tissue damage, why don't we use them all the time? Well, we've done studies with this, and in terms of rebleeding, there's no particular advantage to clips versus cautery, except clips don't cause much tissue damage. On patients with anticoagulants, steroids, healing issues, they're good to use if you can use them. But here is a video, mostly for the gastroenterologists and from Dr. Martin, but he doesn't deal with this sort of thing. He's in a more exalted position now. A 75-year-old Hawaiian lady who came through the emergency department at UCLA with hematemesis, melena, and syncope, so indicating a big bleed. For sciatica, the lady had been on aspirin and NSAIDs, but with no PPI for protection. She has a history of diabetes, hypertension, osteoarthritis, and anemia. In the emergency department, she was hypotensive and had a low hemoglobin. We didn't have a baseline, but because of her general condition or comorbidity, she, at our threshold, was transfused. We wanted to get her hemoglobin above 8. So the question is, what does she have? As a Asian Hawaiian lady, we were concerned about cancer. She'd never had a bleed before. Gastric cancer is an issue. And then because of the aspirin and the NSAIDs, we were concerned about an ulcer. And she may even be H. pylori positive because of her age and cohort effect. And so this is in the duodenal bulb, and it's actively bleeding. And you can see the blood coming out. So I would ask the fellow at the bedside, what are you looking at? And they would say ulcer, and I'd say, how are you going to treat this? Well, this is a device that's a combination of an injector needle with a coagulation. We injected this with dilute epinephrine, 1 to 20,000, pull the needle back, and then we would coagulate this. If you wanted to clip this because it's on the side in the duodenal bulb, it would be very difficult. We've gone over the settings and everything with the folks this morning. There's a residual vessel here, and it's not bleeding, but we want that flattened. Now, in this particular case, this lady actually was on this trial of a Doppler probe. She was one of our patients. We had Dopplered this before. It was positive. We saw where the artery was, which ran along the wall. We coagulated this with firm pressure, and we rechecked it again, and the arterial flow was gone. This lady, however, was put on PPI infusion for 72 hours. What's done in our place now as far as the H. pylori is to, when she's eating again, we check the stool antigen. Now you could do biopsies, but it confuses this, and she had blood in the stomach. It washes away the mucosal layer, and it's not accurate. You can also do a serology, but a lot of these are positive in people that are in their 7th decade. She was positive, and we found that out before she was discharged. She was placed on BID PPI. We don't do a follow-up endoscopy on her, but she's done well. And while she's been on aspirin and NSAID, she has to continue a PPI later on because of this problem. I told you previously, with ulcers, what is the residual blood flow? And it's high. It's above 25% in ulcers, and it's even higher in some other lesions I'll mention in a minute. So this was an opportunity to ask the question, does this Doppler probe, if it's utilized in an interventional study, does it actually improve outcomes? So we got funding from the VA, where I also do attending and work, for a 5-year study, which was complete and is going to be published. It included not just ulcers, but what this is called a doulofoid lesion, named after a French pathologist who discovered this in the 1800s in autopsies. This is an artery sticking through the surface without a exudate or an ulcer. The problem with these is if you look at the histopathology in this one that was resected, there's, if you want, a visible vessel here, which is what that is, but the problem is the artery underneath is big. The reason these are dangerous is because with cautery, often at least a third of these are too big to do coaptive coagulation, and often these current clips are not deep enough to get rid of the arterial flow, and so they rebleed. So these were included in the trial. We also included Mallory-Weiss tears. This is a picture of a Mallory-Weiss tear. In fact, this patient had 2 Mallory-Weiss tears. This is a hiatal hernia. This one's bleeding. There's another one here which we induced bleeding in when we did the endoscopy. This is where it's splayed open. We Dopplered this and it had an artery in it, which is the case when they're actively bleeding. So our current treatment of Mallory-Weiss tears in normal people without cirrhosis is to zipper these closed. If they have varices or portal hypertension, you don't do that because these things have little teeth, and if you puncture the varices, you wish you were in a different place. So, non-variceal. They're driven by arteries underneath. So to answer the question about whether this influences outcomes, we did a randomized controlled trial with the purposes in mind to compare the 30-day rebleeds of the index lesions for patients treated with standard visually guided hemostasis as compared with Doppler-assisted hemostasis. And then we, of course, looked at other outcomes, including surgery for bleeding, death, complications, other GI bleeds, hospital days, ICU days. So for the standard group, gastroenterologists may be interested in this. We used either hemoclipping or multipolar probe, that's bipolar technology, with or without dilute epinephrine injection, and that was used without any Doppler interrogation. And the endpoints visually were control of bleeding, flattening the visible vessel, or clipping it. and then this footprint effect, which we've discussed. For the Doppler group, we interrogated the lesions before we did any treatment at one of the two lower settings, lower intermediate, with this disposable probe at the bedside, and then we applied standard therapy, visually guided. We checked it afterward if there was still residual blood flow, arterial blood flow, and if the gastroenterologist thought it was safe to do so, they then applied more therapy, trying to either reduce or get rid of the arterial blood flow. What were the lesions included on this trial? There was 148 patients randomized. 85% of them were with ulcers, duodenal ulcers, esophageal ulcers or hiatal hernia ulcers, anastomotic ulcers, or the other group, large group of doulofoils, nearly 13%, and then a few Mallory-Weiss tears. So those are non-variceal upper GI bleeders. Looking at what risk factors are, how did they compare? Well, everything we could think of, including aspirin, NSAIDs, warfarin, other antiplatelet drugs, and so on, were the same. Transfusions, you look at the transfusion requirement, about 3 units FFP and some platelets. The only thing that was different is a higher prevalence of aspirin ingestion in the Doppler group beforehand. These show the outcomes according to the stigmata of hemorrhage. And some of you may argue that we're lousy endoscopists, because look at, in the active arterial bleeding, 50% of those patients rebled. Now this is referral hospitals. In the Doppler group, 28%. Not all of them had further treatment for reasons, concerns about safety, access, clips not sticking, etc. And it goes down the way here. Look at flat spots, which are not treated by most people, but in the standard group, flat spots were not treated, 19% not treated endoscopically. That's the current standard of care. 19% of them rebled. In the Doppler group, patients with flat spots that had an arterial signal, which included about 40% of them, were treated and none of them rebled, and oozing, it's low. So overall, the rebleeding rate in the standard group is 26%. That should remind you of what the residual blood flow effect was found in the cohort study of ulcers. It's almost identical, it's 27%. In the Doppler group, it's still 11%, but this is highly statistically different, favoring Doppler. If you look at rebleeding by survival techniques in a Doppler group versus a standard group, it's highly significantly different also. Most of the rebleeds are within the first 5 days, but as with other studies, not all of them, particularly in patients with comorbidity, they can occur later. What other measures were seen? Well, the rate of surgery was higher in the standard group. The rate of major complications was higher. What were the complications? Well, unfortunately, 2 patients had strokes. They were under transfused, 1 perforation and 1 pneumoperitoneum. We didn't see any complications in the Doppler group. Again, if you don't transfuse patients appropriately, especially non-variceal older patients, you're going to have problems. CVA is not something that should occur. What about other transfusions? Well, there's a trend with RBCs being lower in the Doppler group and in the ICU group patients, but it's not significant. What have we learned from this? Well, there's an opportunity still for improvement in treatment of non-variceal lesions, and this is one of the opportunities that has a partial solution maybe. This large thing, which looks like a medieval device, is called a Vesco or over-the-scope clip, and that's an endoscope. You can put this on and it's deployed rather like a banding device. We don't personally use this drilling apparatus, but I thought it would be appropriate, since we're near Texas and they have a lot of oil there and everything, to show you this. how does this thing look? Well, it's sort of like any of you that have ever seen trapping in that. It's like a big bear trap. It grabs a bunch of tissue, but we were interested since, we still had 11% in one group, twice that high in the other group, whether this thing would be better for certain lesions. So we were starting a new randomized trial using this Avesco device with non-variceal bleeding, primarily ulcers or Dulafoy's, not Mallory-Weiss, as compared with standard hemostasis, which in general is clipping, standard through the scope clipping. So in the standard group, the first question we wanted to ask is, after the treatment, does the Avesco device, over the scope device, big clip, make the arterial signal go away any more effectively than standard treatment? And if you look at this at baseline in the standard group, 90% of the patients, not all of them, had arterial signal in Avesco. It was all of them. So again, 10 patients standard, 12 Avesco. Study's not done, it's ongoing. The blood flow obliteration rate was, among those that were positive at baseline, 78% versus 100%. So looking at residual arterial blood flow, 0% in the Avesco group. So if you get the thing in the right place, it works. Still 22% in the standard. Rebleeding, 20% so far in standard, 0% in Avesco. So this looks promising. Why are we interested in this device? Again, although it looks pretty horrendous, it doesn't cause a lot of tissue damage. It eventually falls off, it forms a scar, whereas cautery does, and in high-risk patients, particularly those we see in LA that live longer on anticoagulants, aspirin, Plavix, etc., you don't want to cause damage that can make healing worse. So last issue, what are the independent risk factors for mortality? They have been reported, but we've looked at this. One of my French postdocs, who's back in Paris now, looked at this, a multivariable logistic regression analysis on death and up to 30 days in non-variceal bleeding, some 1,200 patients with 106 deaths. Significant in that, this was published in APT last year. Significance, you see the odds ratios here are high cure prognosis score, which we won't discuss, cirrhosis, low platelets, platelet transfusions at baseline, and a lot of FFP at baseline. So any of those. Again, these are non-variceal patients. What was not significant was age, lesion size, red cells at baseline, gender, hypotension or shock, because those guys in the ER resuscitate people, stigmata, hemoglobin, INR, PTT. What about predicting surgery? There were 131 surgeries. What predicts surgery? Non-variceal bleeding, high PTT, and then a gradation. The more RBCs you transfuse, the more likelihood, particularly look at more than 6 units, 8 times adjusted. What is borderline is lesion size, major stigmata, and what actually reduces the need for surgery are hemostasis and older age. So this is a reduction of 42% if you have hemostasis at baseline, so it does work. And what about rebleeding? The chance of that in this multivariable analysis, 330 patients. Male gender makes it worse, high prognosis score, cirrhosis, elevated PT or INR, platelet transfusions, platelet transfusions at baseline, a lot of transfusions. What's not significant is age, lesion size, stigmata, and hemoglobin. These are my group of the bleeding team. Paul knows a lot of these people. Some of them are still staying there. They all haven't moved to Florida yet. And we have research coordinators. And then for you, those of you, I did list general references that you folks can look at. Some of these, my group, the last or I should say, actually, I've participated in the last four of these, but there is a general reference from the Canadians who are still our friends. Thank you for your attention.
Thank you, Dr. Jensen. There's nothing more exhilarating than at 2 a.m. to be called to the ER for an upper GI bleed, and it certainly gets the epinephrine running in many of us. And I thank you for not talking about Blakemore tubes or football helmets.
Oh, we don't.
Yeah, I know.
Football's okay, but not Blakemore tubes.
Yeah. So a question, and I'm grateful also that at your very first slide, you sort of bucked the trend that a physical examination is still necessary because, as you know, many of our house staff and even faculty feel that a physical exam is a thing of the past. So I'm grateful that you think that that's still important in the initial evaluation. The question I have for you, however, is in your large cadre of non-variceal upper GI bleeds, is there any evidence that race affects outcome, or is there any evidence of health disparities that are involved in the outcome of these patients, regardless of the etiology?
Well, for sure, gender, but gender for
Yes.
sure.
Race.
Not ethnic, with the NIH we deal with ethnicity, so no, it has not on upper GI bleeding. It's interesting in the colon for diverticular bleeding, there are, it does, which is sort of surprising. But in either cirrhotics or not cirrhotics, the only thing that does is whether you're male, female. We haven't looked at transgender yet.
And one question about the timing of the endoscopy and the outcome. What do you recommend? Can you summarize that?
Well, it's an interesting question because in our place, it's an artifact because we always, the guidelines by the first author, Barkin, the Canadian, Alan Barkin, you probably haven't looked at those, but they're published guidelines. They say 24 hours, but in our case, in patients with liver disease, it's more like with liver disease and cirrhosis with upper GI bleeding, it's within 12 hours, and the same in, any unstable presumed non-variceal. But we have a bleeding team. So what that 12 hours, I don't get up usually at 2 a.m., but now with octreotide,
They do.
yeah, well, they're young people. They can do that. Our fellows, but usually the timing of endoscopy depends a lot on the comorbidities of the patients, whether they're altered mental status and you have to intubate them, which in a referral center is not uncommon with the liver disease in the older patients, and then, some stability. So we also it has to do with resuscitation. But we have a bleeding team. We're available. We take the calls and try to plan that. But in general, we do cases before midnight or after 6 a.m. We don't come in the middle of the night because very early endoscopy has not been shown to make any difference. And if you don't resuscitate the patient, it actually leads to higher mortality, particularly aspiration and hypotension in the older patients. So it can be a problem. I think you have to moderate this. The drugs, as I mentioned, with non-variceal, if they start the PPIs in the emergency department, there's going to be a delay in endoscopy. It doesn't improve outcomes, but it downgrades the stigmata. With varices, the octreotide, and the other things I mentioned, you may have to give DDAVP and other things related to the assessment of the patient. Personally, I feel it's more important to look at the whole package rather than act on anxiety, because in our place, we only get paid for, if we're lucky, for one endoscopy. So you can't keep repeating these. So early endoscopies, often they find that the repeat rate is much higher too, because the stomach is full of blood or the patient's too unstable to finish the procedure. when we do therapeutics on these patients, sometimes the whole thing takes 45 minutes or so, or an hour. The patient has to be stable enough that you don't hurt them. I think those are the issues.
Last question, Dr. Kett.
I'm concerned that one of the take-home messages here might be that the transfusion trigger should be 8. Go ahead and do that when you have a well-done randomized trial that on an intended treat basis showed a benefit of using 7 versus 9 as your transfusion trigger. And even in your own data, which wasn't significant, that the number of units transfused was such a higher mortality. But using 8 versus 7, you're by definition probably going to give at least 1 additional unit of blood. I'd like you to comment on that.
Well, that's in unselected patients. Now, you can look at the Spanish trial, and there's a lot of exclusions. I would say 2/3 of our patients would not ever be included in the Spanish trial because our patients are too sick. You know, we have ASA 4s, ASA 5s. Look at that trial. I mean, they're not that sick of patients in their child's classification A and B. That's the only group that involved. So I think in unselected patients, the message is that it's a different population than a highly selected, randomized sort of group.
We're going to have to actually end because they're waiting outside.
I don't think we could do that in unselected
Thank you very
patients.
much.
Okay.
That was very clear. Very
Okay, thank you. Thank you for your comment. You're an endocrinologist.
Yes,
huh? Well,
right.